is the share? Okay. To cut a long story short, I think these numbers are underestimates, and we are going to see not 124 million after 20, 30 years, it's probably more like 150 or 200 million people. The rate of rise is just too fast. When this 74 million came, out of the 15 states completed, 7 of them were in the lowest prevalence rates in the Northeast, where people do a lot of exercise, they're not that rich, and so on. Now, with the southern states being completed, Kerala, Puducherry, prevalence rates are going sky high. And now we're repeating the study now in Tamil Nadu because 10 years. So Arunachal Pradesh and Tamil Nadu has been selected for redoing it. And within 10 years, it's unbelievable how much it has increased in Tamil Nadu. So these are moving numbers. Suffice to say that we have large numbers of people with diabetes. And can all these 74 million people afford the latest drugs for diabetes? They can't. So therefore, for the common person, it is still very important. Sulfonylureas, in fact, were one of the first of the oral anti-diabetic drugs to come. Right from 1940s, there was work on it. And by 1950s, the first drugs, tolbutamide and chloropropamide, had come. And since I started very early in my life, at the age of 18, I started working with my father, I've used tolbutamide. It used to be called Rastinon. And chloropropamide was also Diabetes. It was also used. These are only drugs which are available. In fact, in 1970, you see that landmark. 1969, to be precise, was when my father was part of the development of glibenclamide, the second generation sulfonylurea. It's a dramatic change from tolbutamide, chloropropamide to glibenclamide. At that time, it was a fantastic development which occurred. But then we had the second generation, third generation. We had safety from UKPDS. So we had glipizide and glycoside coming in, about which I'm going to talk today. And then we have also the glycoside extended release, glimepiride, third generation. So sulfonylureas have not stopped coming. They're coming better and better. And the modern sulfonylureas are actually comparable to DPP-4 inhibitors or any of the latest drugs. So how are these modern sulfonylureas different? Because they have a unique mechanism of action. I think the top line is getting hidden. So they have a differential affinity for the sulfonylurea receptor. And because of that, they bind more easily and the release mechanisms are different. This actually translates to better safety, lower hypoglycemia. So the modern hypoglycemic, the modern sulfonylureas don't have the severe hypoglycemia, which is, for example, even with glibenclamide, which is, it's not a drug which I'd use in old people anymore because you've got much safer drugs. The most popular modern sulfonylureas are glimepiride and glycoside. I would say more than 90-95% of all the sulfonylureas used in India will be one of these two. And this talk will focus on glycoside, although this company produces both, but they wanted to focus on glycoside. So if you look at the glycoside, is there any way I can get rid of that top thing? I don't want to do something which will, can you pull it down? Lift it up. Okay, now it is seen. Okay, so glycoside in the advanced trial, that was a turning point. We were involved in the advanced trial, and part of India's many people who are involved in the advanced trial, which was done by the George Institute. Now, in the advanced trial, what they showed was something very unique, and this slide I think is very important. With any drug, when you try to get the A1C down, up to 7%, there is no problem. But if you try to bring it to 6.5, you're already going to get hypoglycemia. And to bring it to 6% is almost impossible with many of the drugs. You can't do it with glibenclamide, for example. In fact, 2 trials, the VADT trial and the Accord trial, had to be stopped because people died. And they tried to get the A1C down to 6, and the trial had to be stopped. But in the advanced trial, you can see 81% of the patients had A1C below 7, 65% had below 6.5. No other trial has shown this. And below 6%, 21%, 1 out of 5 on a sulfonylurea, able to get the A1C down to below 6. There were no safety issues. There were no deaths. No severe hypoglycemia, no hospitalization for hypoglycemia. And you can see how it is sustained for years. They say after you use sulfonylurea, sometime it will burn out. No, it's not. For 6 years, 7 years, they're able to continue like this and even longer. issues are there. Okay, so this low risk of hypoglycemia with glycoside is very well known. It has a biphasic pulsatile glucose-dependent insulin secretion. That means only when the glucose levels are high, it works. So when it's having hypoglycemia, it doesn't work that much as it should not. And also restoration, the early insulin peak. We know that insulin secretion occurs in the first phase and second phase. And the first phase, loss of the first phase, that big thing which goes up, that is the primary defect in type 2 diabetes. And that is corrected by giving this particular drug. Now, is it recommended if you have a kidney problem? Now, these are the Kidney Disease Outcomes Quality Initiative, or the KIDOGI guidelines from the National Kidney Foundation. And you can see that whereas glimepiride, you have to be careful if the eGFR is below 30. It's not recommended even, because it's a long-acting drug. Whereas glycoside, below 60 you can use it, below 45 you can use it, and below 30 also you can use it. Of course, the dose you might have to reduce or give it once a day if it's an extended release, but it can be used without dosage adjustment in early stages of kidney disease. As I mentioned, the VLET and ACCORD, apart from the deaths, there was also a lot of weight gain. Whereas in advance, you can see there was no weight gain. Can you believe a sulfonylurea drug which is used with no weight gain? So it just shows why glycoside has continued to rule the roost, so to speak, as far as the oral drug therapy is concerned, even today. Now, this weight neutrality is actually maintained over years. Even in later studies which came, even with the glimepiride, the Carolina trial, for example, showed that there is an initial weight gain. But after that, the weight actually plateaus and actually comes down in Carolina. So this weight gain that we talk about is sulfonylurea. As far as the modern sulfonylureas are concerned, it is more of a myth. Now, glycoside is a sulfonylurea with a difference for the following reasons. First of all, it has a unique mechanism of action. It works specifically on the sulfonylurea receptor on the beta cell. Its efficacy is unparalleled. It will be no exaggeration, whether it's an IPCA talk or any talk, to tell you that there is no anti-diabetic drug in the world today among all the classes that you have to beat a sulfonylurea. Will you believe that or not? Sulfonylurea and metformin, the oldest drugs, are the most potent. You can get an A1C reduction of 2%, 2.5%, unmatched. You cannot get it with DPP-4. You cannot get it with SGLT2. You cannot get it with the GLP-1 receptor analog. So as far as potency is concerned, nobody in the world is going to say sulfonylurea is not potent. It's the most potent. What they are afraid is it too potent? Will it get hypo? Well, you can have the modern one. It doesn't produce hypoglycemia. Cardiovascular safety has been shown, not only in advance, but also in Carolina, where the glimepiride and linagliptin had no difference as far as the cardiovascular. The graphs were one on top of the other. Renal safety, absolutely renal safe. It has no nephrotoxic element at all. And as I just showed, it's been approved by KDIGO to be used even in renal failure. And of course, weight gain is not an issue. So it's a drug of choice in type 2 diabetes management. And I won't say only for a poor man I'll use it. I use it for millionaires and tell them it's a fantastic drug. It's the most potent. Your sugar is severe. I don't think it'll respond to any of the others. And you can even use it in combination. Doesn't mean you cannot combine SGLT2 with this, or GLP receptor analog with this, or metformin with this. In fact, when I was a student in Madras Medical College, one of my early papers, the third or fourth paper I published, was a combination of sulfonylurea and metformin in dogs. We did dog experiments in Madras Medical College. And then with my father, we did the clinical trial. Those are the first in 1974, 75, almost 50 years ago. We have shown that the combination of these work. This is just a small study which we did publish in 2015, where we looked at the extended release glycoside formulation. Objective was to see a simple two-step titration. Can you start with a lower dose and then build it up? And so this is the trial protocol. I won't go through that. So we used a two-step thing. You start with 60 milligram. Then if it doesn't work, you give 1.5 tablets, 90 milligram, because it's a scored tablet, so you can break it. And then you can go to 120 milligrams. Worked beautifully. This is about 700 patients. And as you can see, beautiful effect on fasting blood sugar. Almost you can see and of course it's dose dependent. So as you go higher in the dose, you're getting a significant reduction in the fasting blood sugar. There's post-meal blood sugar reduction. Also an A1C reduction of 1.3%. Now this is in a clinical in a real world evidence. And if you do it in a clinical trial where you select the patient, you'll get probably much more. As I said, you can get up to 1.5 to 2% reduction. Lipid profile, well, it's definitely not having any bad effects. It's not a lipid lowering drug, obviously, so it's not a statin, but we are seeing some improvement, slight increase in HDL and reduction in triglyceride, reduction in the LDL also. Because of the control of diabetes, you get some improvement in the lipids as well. As I said, the incidence of hypoglycemia, very low, not a single case in the trial we had to withdraw because of severe hypoglycemia. So this paper, which we published, highlights Indian evidence to show that 80% of patients are treated with oral drugs, only a third who achieve HbA1c less than 7%, because you're using very mild drugs, probably not using the proper dose, and you have drugs like this which you can use to bring it down. And this is another study from India showing the real-world effectiveness of glycoside or glycoside plus metformin. And you can see that a lot of people achieved the target of the A1C. And if you use the glycoside alone, or you add glycoside plus metformin, you're obviously getting a much better effect. And you can see that in patients with A1C more than 7, it worked, and more than 6.5. These are relatively milder cases, and even there, it has been used safely. And the conclusion from the study is that glycoside can be an ideal choice if sulfonylurea is being considered. There is other evidence from the UK as well. UK was one of the first to use glycoside. In fact, when we were using other drugs like glibenclamide, they use glycoside, but of course for a different purpose. For some reason, glibenclamide, which is so cheap here, was costly in the UK. So because it was cheap, this was a drug which was used in the UK right from the beginning, 20 years. Ever since UK PDS, they used only this. And they've got a lot of experience with the glycoside. George Alberti and others have used that. And here is real evidence, real-world evidence to show that it really works. And this is top people like Melanie Davis and Kamlesh Kunti and others who have shown the real-world effectiveness compared to sitagliptin, almost similar with very little difference in hypoglycemia as well. And glycoside MR is 35% more likely to achieve an A1C less than 7%, and here is less than 6.5%. Now, this is not something which other companies will tell you, or other molecules you can say. 6.5% HbA1c. Tell me how many conference you attended where people are talking about A1C of 6.5. It's difficult. If you're really aiming for tight control, you sometimes need a sulfonylurea. And you can see the sitagliptin is not able to match the number of people who are achieving 6.5. Ramadan is one of the indications for using glycoside. Lots of studies have been done. We have also done one, and others have also done, because that's the time when you fast. And when you fast, you don't want a drug which will produce hypoglycemia. If you stop the drug, they'll get hyperglycemia. If you take the drug, they'll get hypoglycemia. So can you use a sulfonylurea? DPP-4s are promoted for that, saying that you can use it. And of course, you can use DPP-4s. But here is a study which showed that even during Ramadan, 1,200 patients studied with glycoside modified release, virtually no hypoglycemia reported with this. The patients treated with glycoside MR have a low risk of hypoglycemia, and they're able to take it. So there is no need. Of course, now the Ramadan field has gone far ahead. I'm very much involved in some of the research studies. They have guidelines now. When Muslim patients come, you can classify them and say low risk, medium risk, high risk. The very high risk patients, you can actually tell them not to fast because it is dangerous. But the medium risk and the low risk, you can. But some of the high risk Muslim patients, they'll say, no, I want to fast. Even if you tell me it's high risk, I'll fast. So we've used it in such people, and they've been able to take it. So although the risk is there, but God above does many more wonders than we can do. And therefore, if you want one drug, you can use a DPP-4 or you can use glycoside. So I'm going to stop with this by giving you only 3 messages. One is the efficacy and safety of sulfonylureas in general, and glycoside MR is well established to many RCTs. Even more, we have real-world evidence studies of glycoside complementing the RCT data of glycoside and glycoside MR. And glycoside and glycoside modified release can be safely used to navigate type 2 patients. I like that word, navigate. Navigate type 2 patients safely towards individual euglycemic roles in routine clinical practice. And this includes bringing A1C down to even less than 6.5. We always talk about 7%, but you want a drug where you want to hit harder in a younger patient. You don't want to have any hypoglycemia. You don't want to have hypoglycemia. And you want to bring the levels down. Consider a sulfonylurea, and you can definitely consider